Thank you very much again for the invitation, and hello to everybody all over the world. And I would like to introduce a short story that we are still Stone Age people, like you can see here. And we live in a very, very modern world, and we are hunting for modern food. And that's the reason for a lot of diseases which will affect us. One of this is celiac disease. And I would like to introduce some facts and figures to you. And here you can see that we have a genetic risk for celiac disease. And in 30 to 40% of all people in Western countries, you have the genetic risk. But not everybody will be affected. The worldwide prevalence based on the antibody testing is around about 1.4%, and the global prevalence on biopsy confirmed celiac disease is about 0.7%. On the world, the prevalence is very different. So you can see in Africa and Southern Asia, the prevalence is a little bit higher than in the Western countries. Maybe this is caused by different nutritional behaviors. And you can see that females are affected more often than males, and children more often than adults. But there is a bad guy, and that is gluten. So if you look at the wheat in the USA, the protein content between 1900 and today has nearly been doubled. So gluten is a protein, and gluten is in a doubled concentration in wheat, actually. In addition to that, in the US, between 1997 and 2012, the gluten import has raised up to the threefold amount. And in addition, we see that this gluten is included into food production to get a better bread, better dough characteristics. So per person between 1997 and 2012, we have nearly a fourfold increase of gluten ingestion. That means at a daily dose of nearly 1 gram gluten ingested by bread, noodles, and all the other things with gluten content. In comparison, the maximal daily dose for celiac patients lies around about 50 milligrams. So we eat every day a lot of gluten, and if the diagnosis was not done, the people are really affected by that. And there's another thing. Here you see data from the US too, between 1990 and 2010, and the study stopped in between 2010. The column, if you add it at the end of 2010, will end up here. You see here an increasing amount of celiac incidences that are patients who had been hospitalized and were tested positive for celiac disease. The black line is not the trend line. It is the glyphosate amount applied to wheat. And here the authors found out that glyphosate was complexed to gluten by transglutaminases in the body of the patients, making a more immunogenic product, and that leads to the higher incidence of celiac disease in the US. Let's have a look at the biochemistry behind that. We have special trigger factors. One I mentioned before are the internal factors, the genetic risk factors, the HLA, DQ2, and 8. We have gluten as the trigger, and we have other external factors like infections, environmental factors like glyphosate, biological stress, and nowadays we know the microbiome too is an external factor working on our celiac disease development. Altogether, they make an inflammation, and inflammation makes a tissue damage. Together with the inflammation and the tissue damage, we have a failure in the control of the immune response, leading to chronic inflammation response and autoimmunity. The HLDQ2 and DQ8 are surface antigens present on our leukocytes and all our tissues. And they are responsible for the knowledge of the body that some products or some substances are foreign or belong to our body. You can test for these risk factors by PCR methods. How does it work? Into the binding sites of the HLA-DQ2 and 8, gliadin peptides fit perfectly in. So we have the situation that gliadin peptide binds to transglutaminase or is bound by transglutaminase 2, then internalized in the B cell. The B cell presents the complex between gliadin and the HLA-DQ2 or 8 on its surface to the T cell, which binds with a T cell receptor to this complex. And later on, they recognize that this part here is a foreign substance and should be defeated. Then the B cell reacts in the production of various antibodies, leading to autoimmunity, even against transglutaminase. What are transglutaminases? Transglutaminases are a family of enzymes. They are structurally and functionally related, and they are present in many, many tissues. And their physiological function is to translate the structure to form different structures and act on the activity of the proteins, especially those rich in glutamine. So the function of transglutaminases are to modify signaling, to alter the functions of proteins and peptides, and to be responsible for the fate of cells and the extracellular matrix in our different tissues. Here is a list of all transglutaminases in our human body. They are numbered 1 to 7, and we have the coagulation factor 13 as the 8th transglutaminase. They all are located in different organs. Here you can see transglutaminase 1, 3, and 5 are more in the skin present. We have the transglutaminase 2, which is present in the gut mainly. We have the transglutaminase 4 present in the prostate, and transglutaminase 6 in the central and the peripheral nervous system. They have different purposes, mostly to the integrity and function of the tissues. That means the integrity and function of epidermal barrier, wound healing, and so on. But to spermatogenesis or neurogenesis are the functions they have. In the case of mutations, you find several diseases, for example, ichthyosis or cancer or prostate carcinoma. In the case of autoimmunity, printed in blue, you see the dermatitis herpetiformis, celiac disease, subfertility in men and in women, or the neuroceliac disease as gluten ataxia, gluten encephalopathia, or anything else. And even in the copulation, you find the factor 13 deficiency leading to bleeding disorders. There are several external factors beginning in the development of our human being that starts in infant feeding. You see that there is a positive correlation between the incidence of celiac disease and the amount of gluten ingested in early lives. There is no association found until now between the mode of delivery and the exposure to antibiotics. But there is a good correlation between infections, for example, especially rotavirus, norovirus, and enterovirus in childhood enhances the risk to develop celiac disease. And last but not least, even our microbiota have an effect on the development of celiac disease or the tolerance against gluten, because they modulate the host immune response, and especially proteobacteria express gluten-degrading enzymes that makes that are synergistic to a gluten dependent inflammation. So what happens? We have the trigger, maybe an infection or too much gluten in youth. And all that leads to the fact that gliadin can pass through the epithelial cell into the body. Here, it meets the tissue transglutaminase, complexes with the tissue transglutaminase, or is deamidated to deamidated gliadin. All those, the gliadin, the deamidated gliadin, and the complexes with the transglutaminases are internalized in antigen-presenting cells, processed, and then presented to T cells. T cells react on this presentation with the induction of sonulin, leading to a breakdown of endothelial barrier function and the possibility for more gliadin to enter into the body. The T cells produce cytokines. The cytokines lead to apoptosis and making it even more worse here to enter gliadin into the body. Cytokines too attract lymphocyte into this epithelial tissue, which you can see in the microscopic pictures. And finally, the B cells produce antibodies against gliadin, endomucil antibodies, and tissue transglutaminase. Altogether leads to celiac disease with crypt hyperplasia, villus atrophy, and lymphocyte infiltration. And these affected cells produce intestinal fatty acid binding proteins, which you can use as a diagnostic tool you see later on too. So let's have a look at the clinics. The awareness for celiac disease is rather poor. The prevalence I mentioned in the first slide is about 1 to 2%. But if you remember your last congress or the last journal you read, there's much more information about ulcerative colitis or Crohn's disease. But they are rare diseases. That's the reason why 1 of 4 patients with celiac disease are undiagnosed. And that's the reason for a delay in diagnosis between 10 and nearly 13 years. We have constantly updated guidelines. We have tests available, and we know about the risk of complications in celiac disease. And we know that a gluten-free diet improves quality of life of all patients. But on the other hand, we have a patient-induced restraint. They don't want to talk about that. We have a lack of clinical knowledge and an unfamiliarity of doctors with diagnostical methods. And they are mostly unable to interpret extra-intestinal signs and to see that there is a link or glue to celiac disease. And there is a medical inertia to the condition gluten-related diseases. So during lifetime, we can see 4 different courses of celiac disease. The classical one starts in childhood and stays over the whole life. Then we have the so-called extra-intestinal celiac disease, which starts in early childhood, then disappears in puberty and reappears in the adult, mainly as an extra-intestinal manifestation. And we have the adult form, which was not seen in youth, but appears in the adult. And last but not least, there's a threshold. And under the threshold, you find the subclinical patients, which are not visible in the clinics. The problem is that we have some time points where we find complications like cancer, osteoporosis, malabsorption, infertility, and neurological diseases. They are more early in the classical form and later in the others. And another problem we have, 27% of all the patients present with the classical symptoms like diarrhea, weight loss, and malabsorption. But 21 of all celiac patients never had symptoms. And the majority of 52% comes with a constipation or anemia, osteoporosis, alterations of the liver enzyme, neurological disorders, or the dermatitis herpetiformis. So I want to look shortly on anemia. In this study, they looked for people with anemia and wanted to find out what is the reason behind this anemia. And you can see that in a lot of patients, celiac disease was the cause of the anemia. And were very young patients. And what is rememberable, this anemia is most often inexplicable and it always evades the treatment. So if you give to these people iron supplement, it will not affect the iron content in the blood. Another problem is osteoporosis. I would like to present here a case report of a 34-year-old patient with spontaneous fracture of the 10th dorsal vertebra. He was diagnosed for osteoporosis. And other fractures followed, like you can see here. He was seronegative for celiac disease, but he showed villus atrophy, and he was HLA-DQ positive. So he was diagnosed for celiac disease, and it was interesting. He could provide a photo from his childhood, and as you can see here, the boy shows all signs of malnutrition. The third I would like to introduce to you is the neurological manifestation. The first hint was given in 1908. And here you can see the first photograph of celiac disease, that there is a neurological abnormality. And in 2013, transglutaminase was identified as the autoantibody in the diagnosis of neuroceliac disease. And you can see here there are gluten-related disorders like ataxia, peripheral neuropathy, epilepsy, movement disorders, headache, cognition, and myopathy. And they often show improvement under a gluten-free diet. And movement disorders, there is Huntington's disease. Cognition, there are Alzheimer's disease, schizophrenia, autism spectrum disorders, or Down syndrome. And myopathy, that is multiple sclerosis. All these patients should be considered to have maybe an underlying celiac disease. Not all, but a lot of people should have this underlying celiac disease. And I want to mention that in all ataxias, 20% can be deduced to gluten ataxia. What happens in neuroceliac disease? It starts, as I mentioned in the previous slide, in the gut with all these cells of the immune system. But then there is a question mark, maybe pro-inflammatory cytokines or sonulin, haptoglobin, occludin, claudin, or PPR gamma can make that the antibodies can enter via the blood-brain barrier into the brain, leading to destroyment of neurons in the brain and leading to, for example, ataxia. The signs are, for example, an abnormal gait or the Romberg sign. I will show it later on. Sensory symptoms like tingling, stabbing, numbness, muscle pain or weakness, and you can see it in the pictures as a cerebellar calcification or a cerebellar inflammation. Here I would like to show you a short video which was recorded in Spain on an adult male patient. On the left side, you see him before the gluten-free diet with his ataxia. He was not able to walk independently. On the right side, you see the same male person after a 3-month gluten-free diet, and you see clearly the improvement. And that is the Romberg sign. On the left side, you can see that he can't stand alone. And after 3 months gluten-free diet, he was able to stand alone. We have a tool to diagnose this neuroceliac disease. This is the neural tissue transglutaminase, or TG6. In a study in Sheffield, they showed that a number of 100 patients with newly diagnosed celiac disease had a lot of neurological deficits. And 40% of those had circulating antibodies against this TG6. And there was a link between the reduction of volume in the brain regions and the celiac disease. In another study, they looked at 30% of this cohort after 7 years. And they saw that some factors improved. For example, headaches. After introduction of gluten-free diet, only 20% had headaches. But some other symptoms stayed or exaggerated, like, for example, gait instability. So to prove the adherence of the gluten-free diet, they tested for EMA, TG2, or anti-gliadin antibodies. And they saw that at the beginning, there were nearly all of them were positive for these parameters. And after the diet, it reduced dramatically. But if you look at the anti-TG6 antibody positivity, 37% were positive at baseline, and it stayed nearly at after 7 years of gluten-free diet, indicating that they were not really adherent to gluten-free diet. And the recommendation is that one should do a repeated screening, not only for TG2 and EMA, but too for anti-gliadin and especially TG6 antibody testing. And the European Society for Celiac Disease has formed a guideline for celiac disease and other gluten-related disorders. And they say that gluten-induced neurological manifestations can be seen in adults as well as in children, that anti-TG6 can be found in these patients with neurological involvement, and that there is a diagnostic tool to identify these patients with neuro-CD. Why should we do diagnostics? Celiac disease enhances mortality. And the other thing is that if you look at the gluten ataxia, I mentioned it here, it has mainly a partial recovery by gluten-free diet or stabilization. What does it mean? If we start in an early phase with a gluten-free diet, we can reach a restorable stage, nearly normal. But if we pass a threshold, we come into a non-restorable stage and can only stabilize the patient's situation. So it's very, very important to identify these patients very, very early to avoid the wheelchair. And there are a lot of patients who are not affected by celiac disease primarily, but who are at risk to develop celiac disease with their underlying disease. For example, from the skin. We know that people with psoriasis, urticaria, rosacea, or malignancies may have celiac disease underlying. And we know that people with endocrine organ diseases like diabetes type 1 or Hashimoto's disease may have a secondary celiac disease. And in the dental offices, you see patients very early with enamel defects. They are symmetrious and they are often accompanied by aphthostomatitis or dry mouth. Then there is a risk of celiac disease. We have people, men and women, with problems in infertility. They may be suffering from celiac disease. And all people with chromosome anomalies like Turner syndrome or trisomy 21 are at higher risk for celiac disease, as well as people with bleeding disorders like factor 13 autoimmunity. So we have an individualized approach based on immune diagnostic products. We have the gut, we have the skin, and we have the mind. So we can take blood and stool as source to detect. And then we can do a gastrointestinal screening, a dermatological screening, or neurological screening with specific anti-transglutaminase antibodies. Be aware that there is no IgA deficiency. If there is a deficiency, then we do have false negative results here in this test. And if you have an IgA deficiency in the patient, you have to skip to IgG testing. We also offer an anti-TTGS IgA stool kit to see if there is an early reaction in the gut, maybe after ingestion of gluten. And always keep in mind that there might be a cross-reactivity between TTG, ETG, and NTG, and that if you are positive for TTG, you can be later on positive for NTG. So you have tested your patient and you have a lot of results. What can you interpret here? We have here the celiac disease subgroups, and you can see that 4 of those have a positive result in TTG, anti-TTG testing. The seronegative form has no antibodies, but it is positive in MARCH 2 or 3. And in the neuroceliac disease, you will have a positive results in TG6, and in dermatitis herpetiformis, you more often have a double positivity in TTG and ETG. You can discriminate celiac disease easily from wheat allergy or non-celiac gluten sensitivity, because these patients have a clearly negative result in all these specific antibody tests and no MARCH 2 or 3. The HLA-DQ 2 and 8 must be positive in all the celiac disease forms. And you can do other testing that might be positive in wheat allergy and NCGS2, that is deamidated gliadin peptide and agar. And if you test for intestinal fatty acid binding proteins, you will find mainly positive results in refractory celiac disease. That can be a diagnostic hint to refractory celiac disease. You have the patient and you recommended a gluten-free diet. So you have to monitor that, and you can do that with a questionnaire. That is time-consuming and escapes reality, because the patient, as well as you as the interviewer, you interpret the question and the answer. You have the symptoms. They are quick in onset, but they are very variable, and not all patients show the symptoms. And you have anti-TG2 serology. They are, you can see here the courses. They are widely used, but they are very slow. As you can see here, after the introduction of the gluten-free diet, the anti-TG antibody titer drops down, but it takes 2 to 4 weeks to go into a low level. And on the other hand, if the patient starts eating gluten-containing diet, it increases again, and this takes a lot of time. So it's useful as a follow-up biomarker at the follow-up appointments 3-6 months after introduction of gluten-free diet, and at the annual examination. And I compared to the diabetes monitoring, where the HB1AC measurement, it's a long-term marker for a good adherence to the gluten-free diet. And you can differentiate between complete, partial, and non-adherence in the patient. Another tool in your toolbox are the gluten immunogenic peptides, or short GIP. They are detectable in feces in the windows of opportunity between 2 and 7 days, and in urine in between some hours after gluten challenge. They are non-invasive, easy to use, even patients can do it, and highly sensitive. And they are useful to detect traces on ingested gluten, as the so-called dietary errors. And there I compare it again with the diabetes monitoring that is comparable to the glucose measurement in diabetes. And last but not least, the biopsies. They are very invasive, and very slow, like the serology. And they should be reserved to cases with no clinical improvement and no decrease in the serological marker to exclude refractory celiac disease. So here again, an overview over all the methods for the gluten-free diet monitoring. You have here the different parameters I mentioned before, and you have here the different time points. Those are directly after the initial diagnosis, the 3-month and 6-month follow-up. Here you should clearly look for a good adherence, and maybe you have to do a dietary advice if there are some figures evading the normal. And after the first year, you should do a 12-month follow-up, a yearly follow-up, and you should do all the parameters, where the anti-NTG at the moment is a best practice point. It's an add-on analysis to see for neurological complications, especially in adults. And the urinary GIP you should do if there is an acute onset of symptoms, because it has a very short window of opportunity. And the fecal GIP is the gold standard for the GFD monitoring and gives you a good information about the adherence. So I'm at the end of my talk, and I would like to give you the final message that you should do patient-centered diagnostics. You have the tools to detect gluten-related diseases in any organ and to monitor the adherence to the gluten-free diet. Thank you very much for your attention.
Thank you, Dr. Bastian.
So
we have a question for you. Could the increase of celiac disease in the adulthood due to be in decrease of consumption of gluten in the early ages?
Of course, the gluten content in the nutrition in the early ages is a factor for later onset of celiac disease. It enhances the risk for celiac disease. Was that the question?
Yes. What is the better way to reduce the ingestion of gluten in a patient?
Pardon? Could you please repeat?
What is the better way to reduce the ingestion of gluten in a patient? Maybe to recommend, or what is a better way to recommend?
Yeah, you should inform the patient about all risks, which could be if he does not adhere to the gluten-free diet. That is, for example, cancer, early death, or complications like neuroceliac disease, which will end up in the wheelchair if it is untreated. So that are very severe reasons to adhere to the gluten-free diet. I know from several talks to specialists that especially in puberty, the people ask whether they really have celiac disease, and they question the diagnosis. So maybe it would be good if there was a diagnosis in childhood. You should re-diagnose in the puberty to convince that this person is really a celiac person and that he should adhere to this diet for his total life.
Another question, is there any other food restrictions recommended to have a better adherence to the gluten-free diet?
No, it's only gluten, which should be reduced. and you can find a lot of recipes in internet meanwhile to produce your own bread, your own noodles, and especially in supermarkets. I don't know in South America, but in Europe, you always find a complete panel on food and today, and it's not anymore very expensive. But you should be aware that it has a very, very good quality and a very reduced amount of gluten.
Another question, Dr. Sonia, do you recommend the genetic testing in newborns, babies?
No, the PCR testing is not a screening parameter. It can only be as an add-on. 30% have this genetic risk, but only 1.4% of all people will develop celiac disease. So it makes you troubling whether your child will develop celiac disease. You have to be aware of having celiac disease, yes, but no genetic testing.
Thank you very much, Dr. Bastian. We are going to send more questions to you by email so you can answer to our participants, and I'm going to send them back the responses, okay?
Okay.
Thank you very much. We loved your presentation, and we hope to have you again here soon.
Okay. Thank you very much for the invitation. Have a nice day.
Thank you.
Bye.